Hello, everybody. Welcome to a Tuesday edition of VMR. Today, it's my great pleasure to have Mingyu, who's going to discuss with me or co-discuss with me. And everybody I've been on this platform for quite a while, so I don't need to introduce myself, but I'd love to introduce Mingyu, who's just been a new addition to our team and brings a whole different experience to our group here. And currently she's in China. She's so committed. She logged in from China to come on VMR and co-discuss. So I'll ask Mingyu to unmute her mic and also introduce herself.
Hi, very nice to see each other again from a different physiological location. I'm currently a hospitalist at in Oregon, and I'm also an IMG. I graduated from Boston. I'm from China, but I did residency in Boston, and then I came to the West Coast. I was I've been on this team, CPS Hours, for a long time, and finally excited to be joining the family and learning a language with each other. I'm so excited. Yeah.
We're very excited to have you on board as well. Now, I'm also an IMG, so that makes two of us. So is always a difficult pathway to get in, but once you get in and are on your pathway and working, everything is so much better. So we have a lot of IMG colleagues here who are on the pathway to match into residency, are pretty much following behind us and motivated by what we do here. So we want to be at least encourage our IMG colleagues here that tune into VMR. So today, Ricardo actually has a case. I'm going to ask Ricardo to unmute and say hello, and how are things today?
Hi, everyone. Nice to meet you all. Thank you for the opportunity to be here. And yeah, very happy to share this case with you all.
Awesome, Ricardo. I really appreciate you bringing this case today to us. So let's launch the whiteboard and proceed with the first aliquot.
Sure, thank you. Okay. Yeah, so basically, this is a female patient, and she's 59 years old. And she basically comes due to a 3-week history of lower extremity edema.
Yeah,
Should I go ahead?
Yeah,
take a stab
I can
at
take
it.
a stab with a chief complaint. I think lower extremity edema, I think the approach to that, you would think about the major buckets of, it could be a decrease, like increased venous pressure, like, for example, from heart failure, or decreased oncotic pressure in the tissue, especially low protein status, like hypoalbuminemia, either from the liver disease or renal, like nephrotic syndrome, or the leakage of the vessels or lymphatics, so like lymphatic tissue disease, like that dilatation of the lymphatics. Of course, then a low protein intake, also going back a little bit, also could contribute to the hypoalbuminemia. So 3 weeks history is like a subacute. So I think the differential still holds true for these big categories. I would be curious to learn about the associated symptoms. Most people do have respiratory symptoms from like third spacing of pleural effusion, like effusions in the belly or the lung. But also observe the urine, any liver problems, and the distribution of the edema, like whether face is involved, things like that. I think I'll pause here and see Ravi.
Absolutely wonderful, Mingyu. That's exactly what I'm thinking. I was like imagining a leg and then looking, but then I'm like, I need to be careful and not fall into that pitfall of just examining the leg, but looking north. So looking at the leg, looking to the kidney, looking at the leg, looking at the heart, looking at the leg, looking at the liver. So areas where you kind of mentioned that they could be chronic disease. We don't have the past medical history, but my question would be, what's in the past medical history that could easily explain this? Is this a new condition, or is this an exacerbation of an underlying condition? Like you mentioned nicely, the volume, the oncotic pressure, the protein. So it kind of be valuable. So I'm going to look, is this a localized issue? Is this a systemic process? So I'm right on board, hanging on to your coattails, thinking along the same sort of framework that you nicely just put out there for everybody to ponder over. Back to you, Ricardo.
Sure, thank you. Okay, so in regards like to the HPI, the patient is a patient that is actually in jail. She is in custody, so she's African American, 59 years of age, and she refers that this lower extremity edema happened, started to happen 3 weeks ago because she refused to take her Lasix as a way of protesting or rebelling to the jail. And before she arrived to the emergency department, she received 80 milligrams IV of Lasix, which also she says that improved a headache that she had associated with the lower extremity edema. She denies chest pain, shortness of breath, abdominal pain, nausea, vomiting, diarrhea, dysuria, or any trauma.
I'll kind of just sort of jumpstart there. So quite a few things that Ricardo mentioned. It was interesting that she was just given a shot of Lasix to see, and right off the bat there, if there was, you kind of expect a outpouring of urination with that Lasix and see if some of that edema would subside. But the effect usually is an immediate, it's sort of a boxcar effect. So there's some intravascular volume depletion and then the movement or mobilization of fluid from the extravascular space to take up that void that's intravascular. But you mentioned there's no shortness of breath, so it still won't rule out congestive heart failure. So that's still on the table as a possibility. Other systemic issues like Ming you had put out there, could there be kidney issues? Could there be liver issues? So those things are still at play. And then we also have to do a dive into the vascular system itself. Could there be some clog within the vessel? So namely a deep venous thrombosis causing something like that. I forgot to ask, is this bilateral or is it unilateral? I didn't ask that.
Yeah, it's bilateral. It's completely
Bilateral.
symmetric with phobia,
Okay.
grade 3. Yeah.
Okay, so interestingly, yeah, bilateral DVT is very rare. I've probably seen it in malignancies, so the burden of hypercoagulation has to be very high, unless you have a thrombus within the IVC causing that, or a tumor thrombus, something like from the kidney. So something like renal cell carcinoma invading into the vessel. So at this point, bilateral, my theory is still along those lines, looking at hydrostatic pressure, oncotic pressure, localized obstruction in the venous system, as well as the lymphatic system, as Ming you had mentioned. And then this thing about shortness of breath, I don't know if that adds to, or does it take off the table possibly congestive heart failure? This could be a new manifestation of congestive heart failure. So still those things we have to consider. Anything else, Mengyu, that while I'm kind of...
Oh yeah, I should have to pick the first step because otherwise I don't have too much to add. But yeah, at first when I heard about the prison, I was thinking about any exposure that's unique to the patient or risk factors. So I thought about some infections that could be associated with nephrotic syndrome. Although I think that's a little bit too early to call it. So probably we'll hear more about the past medical history and all that. Yeah, and it sounds like I think regardless of the etiology, as Ravi mentioned, like a liver or a kidney, or especially if kidney and heart failure are causing this picture, having Lasix would help with the decreasing the intravascular volume. So so that for now, I think the differential still holds true for all of those.
I just want to jump in. I forgot to integrate the Lasix improving the headache. I've never seen Lasix improve headache, but is this sort of an indirect action on maybe hypertension causing a headache? Maybe the patient had a high blood pressure, volume overload. Lasix did improve that mildly, maybe. So there is some sort of effect that the Lasix is having on this headache. So I'm wondering if there's any more data that can sort of clarify what's going on or what is unfolding in front of us with this patient. Back to you, Ricardo.
Sure. So now I'm going to say like the primary medical history. So this patient has hypertension, hyperlipidemia, chronic kidney disease. Also, she has chronic active hepatitis C, heart failure with preserved ejection fraction, and type 1 diabetes. Do you want me to continue or do I stop?
Defer to you, although I think we already have a pretty rich background here. So I'm happy to start talking, unless Ricardo, you want to share more about the case. I guess.
No, I think I can let you guys discuss.
Yeah, okay. I think, yeah, the background is really rich and could really tie into the patient's presentation. For example, what jumps out to me first is the interesting things like hepatitis C, which as mentioned earlier, I was thinking about certain infections like HIV, Hep C or Hep B, those could be associated with nephrotic syndrome. For Hep C specifically, it's usually like MP, I think it's MPGN, but also possibly other like membranous nephropathy or other etiologies. Would also be curious to learn the HIV status as well, which could be associated with FSGS and Hep B, so membranous nephropathy. And then it sounds like she also has history of HFrEF. So this picture could also be as simple as a heart failure exacerbation. Especially if as Austin mentioned in the chat, like in a prison system, if they're not getting their medication as appropriately, then they could lead to exacerbations, which is unfortunate. And of course, the hypertension, CKD. Curious what stage of CKD she's in, but wondering the underlying etiology, whether that could be related to or has a direct effect of something chronic going on. I should also mention Hep C could also be associated with, I think everybody knows the cryoglobulinemia picture, which could also cause vasculitis in the kidney. Yeah, and diabetes, yeah, might be the reason for her chronic kidney disease. I'll pause here.
Oh, Maggie, you just wonderfully laid out all the possible conditions here. I think you kind of have to be judicious in that the diagnostic goalposts appear to have moved closer with this history. It kind of explains everything that's going on with this patient, but this is VMR. So I expect the diagnostic goalpost to move further away with the next aliquot, and it'll get interestingly much more difficult. But I think everything you mentioned there related to the breakdown of the hepatitis C and the cryoglobulinemia and all the different kinds of, even Shema put in chat, all the different kinds of nephrotic syndrome and the conditions that can be associated with that is just remarkable. And I'm just eager to see what else Ricardo is able to give us that might help us to kind of, we're sort of at a crossroads, which pathway should we go down in relation to all the theories that you had just mentioned. So I'll swing it back to Ricardo.
Sure. So I'll start with the social history. So this patient has an extensive use of drugs, including alcohol, marijuana, methamphetamine in the past. Since she has been ill for a while, she has like not used them for a while. And obviously, and also she has never smoked. In regards, do you want to stop like I stop or do I continue?
I think you continue.
Okay, perfect.
Yeah.
Yeah, so medications are basically 16 units of subcutaneous insulin, aspart, glargine, pardon, and she also uses amlodipine 10 milligrams per day, atorvastatin 10 milligrams per day, guanfacine 1 milligram per day, and lisinopril 40 milligrams per day. And she was taking Lasix, but as I previously mentioned, she refused to continue taking them.
Yeah. So I think now we have additional information from social history and medications. I think a lot of the drugs, depending on what drugs, could definitely contribute to chronic kidney disease like meth. But also there's like association if there's a mixture with an altercation with other medication that could cause like vasculitis. I think it's phomepis or something like that, causing vasculitis and renal disease. I would say the medication, I think she's on some of the standard medication, like ACE inhibitors for her presumably diabetic, all her chronic medical conditions, including diabetic nephropathy, which is of course another major category causing the problem. I think so far differential still, and then amlodipine is the last one, CCB, that jumps up to me, which could be associated with lower extremity edema, although I think we kind of have to assess other etiologies before attributing to this, or unless this is a new medication and fits the timeline.
Oh, maybe that's a great breakdown of medications. I was going to say, even, we always mention amlodipine causing lower extremity edema, but not to this degree that we have, but it's something to think about. But maybe we did add another layer onto the edema. So stopping the amlodipine may be wise at this moment. And definitely a lot of stuff that can explain here, but I'm really intrigued to see what the exam shows. I think the exam will at least allow us to clue into which area there may be issues going on. And then some people mentioned the urine and also the chemistry will be very helpful. So I'm kind of eagerly awaiting. So maybe we'll dive into the exam and then also some of the laboratory data, if you may, Ricardo.
Sure. So at the patient at the ED had a blood pressure of 177, 115. Respiratory rate was 17, saturation 95% at room air. So the heart sounds were normal, S1, S2 without S3 or S4. There were no crackles, there was no ascites, and there was grade 3 lower extremity edema with phobia and tenderness. The neurologic exam was normal.
Yeah, so I think I'm hearing lower
ratio was significant. So the albumin creatinine ratio was significant, and we definitely are in the domain of nephrotic range proteinuria. So now we need to figure out which, if any, of the other markers. He was still giving us some more data, which will help us move the needle in trying to figure out which one of these is the cause. And I think ultimately, if the diagnosis is not discovered, then a renal biopsy will be imperative for this patient. Is Ricardo back?
He's messaging on mute.
I just need to share my screen. Make me co-host, please.
Ricardo is leaving us too much suspense about the ending of the case.
Yeah, actually found is 15 to 30% of the adult population is positive for ANA. So it's not remarkable to see it, but we got to be careful that we don't just use that and go off on a wild goose chase.
Hi everyone, sorry for not rejoining. So
oh, no problem. Ricardo, nothing was working without you.
I was waiting for a WhatsApp message and then I saw that everyone was here and I was like, oh my God, I feel so bad.
Oh, that's okay. That's okay. Yeah, you left us hanging, so we're under a lot of suspense, waiting for at least the next aliquot.
Thank you.
Yeah, maybe before the next aliquot, I was wondering, Ravi, if you have any interpretation of the echo findings.
Yeah, let's see the echo. So there's what I saw was biatrial enlargement. So it looks like this patient with HFpEF, and I mean the most likely cause of that's going to be afterload, increased afterload. So the blood pressure. So the patient probably when you have kidney failure to this degree, the blood pressure, of course, the blood pressure is going to be elevated. And looking at the medications, the patient's only taking amlodipine. I'm not familiar with this guanfacine. If it has an alternative name, so it looks like the blood pressure is not controlled, and that can confer increased LV, LV mass or increased pressure, and that causes at least this diastolic dysfunction that you get, a narrowing of the LV chamber, and hence pulmonary edema because of that. But the biatrial enlargement, I guess, due to chronic increased pressures. I mean, the main cause of, I wonder about the pulmonary arteries though. What's going on there too? Is there a component of pulmonary artery hypertension as well? And that you can get in.
Pardon.
Go ahead.
Yeah, someone asked like if I could repeat the findings. So the findings were bilateral enlargement, grade 3 diastolic dysfunction, severe pulmonary hypertension, and there was also, as Ravi mentioned earlier, bilateral enlargement. And the ejection fraction was 55 to 59%.
Yeah, so sounds like the EF is normal, which is good. Maybe her so she have I thought it was HEPRAP, but anyway, it's great. I think the severe pulmonary hypertension, I was thinking, I mean, it could be could be the group 2 pulmonary hypertension due to underlying heart failure. Though depending on the severity, think if there's an autoimmune picture in the patient, then group 1 could be considered. So far I would just interpret with caution. I think sounds like she has really bad underlying heart disease. I think that could explain the severity. Although echo is more like a screening test, that the only way to confirm that the actual degree of severity is to do a right heart cath, but we might not need that right now.
Yeah, I do think let's reflect back on the kidney and see, but you make a very strong argument, a compelling argument that connective tissue disease, although the screening test ANA is negative, anti-double-stranded DNA, but and also we've taken off HIV off the table. So I'm gonna still pursue the kidney and ask Ricardo for the next aliquot to see if we can at least get closer to what's going on with this patient. Back to you, Ricardo.
Yeah, so since this patient had like a worsening of the kidney function it was so acute, and it had like edema, we ordered a renal duplex, and the renal duplex showed the following. It showed that the aorta velocities are low, the right resistive indices within the kidney are elevated, the left mid aorta velocity is significantly increased without focal stenosis, and they also said that the report that there was possible tortuous area of vessel or stenosis with suboptimal imaging, but like it said like clinical correlation, so like tried to correlate clinically, but there was no like diagnosis from the radiologist or from the person who did it.
That's a very interesting finding. So the velocity is low, so usually that means to me like a stenosis somewhere along the vessel. I think I heard renal artery or renal venous flow is low. Sorry, Ricardo, can you clarify, is it the artery or the
aorta velocities are low throughout. And then he said that the right resistive index within the kidney are elevated, and the left mid aorta velocity is increased.
Yeah,
right index. Oh, you're talking about the renal arteries, right?
Yeah, I'm thinking the same thing here. It's very odd. I'm not one to sort of dissect these kind of studies daily, every day, but it's exactly what you mentioned. The flow is low, and what exactly can be going on. So I was wondering, people had mentioned earlier, yes, nephrotic syndrome is immunocompromised state, hypercoagulable state. So could there be tumor? Could there be tumor embolus? Could there be thrombosis within this area? That could be part and parcel of this condition. Could it be secondary? It could be instigating this whole effort. So I'm kind of wondering, but I'm not able to really process it in that we explored the heart. There's something going on in the heart. We explored now the kidneys and the legs. Now, sort of early on in the process, the legs were signaling something going on in the leg, in the kidney. Sorry. So I definitely want to get at least more data for the kidney now. And this is there constriction somewhere that there's low blood to the kidney, but it wouldn't. The kidneys are having trouble here. And I think there is a process that's underlying all of this. And maybe this low flow state is secondary to all of this. So I'm going to swing it back. Any other thoughts, Mengyu? I'm not too sure. I don't interpret these kind of studies often.
Yeah, I was thinking if there's a vascular complication, it could definitely contribute to the degree of creatinine elevation if it's a fast, rapid elevation. But otherwise, I feel like we're maybe slowly moving towards a renal biopsy if other labs are revealing, or especially if there's still concern for lupus or any other concern for lupus, then definitely like a renal biopsy would be the next step. I'm curious to see during the hospitalization the trend of the creatinine. I think that will help us see if it's something that's hemodynamic or and the progression of renal glomerulonephritis.
Back to you, Ricardo.
Yeah. So yeah, well, actually, the patient, like the creatinine continue, like we started 80 milligrams of furosemide twice a day. And at the beginning, like there was 1.5 liters of urine output, but then the urine output decreased to 700. And so there was like 1.5 liters. So we intended like to increase the dose of furosemide to 3 times a day. So 80 3 times a day. And after that, like the urine output decreased to 700. So we consulted the nephrologist, and the nephrologist basically decided to give a dose of 50 milligrams of chlortalidone every 12 hours. And with that, the urine output increased from 700 to 3,900. The creatinine improved a bit because, as I said, it was earlier in 4.5, but then when the urine output decreased, it rose until 5, and then like when we gave chlortalidone and the urine output improved to 3.5 liters, the creatinine improved a little bit, 4.8. So with this patient, we basically ordered antiphospholipase A, thinking on membranous nephropathy. We were also concerned with her drug use, and for possible FSGS, we're also concerned possible amyloidosis, since this patient is Black race, and in Black race, it's reported like there's more prevalence of transthyretin amyloidosis. However, this patient didn't have like any neuropathy or anything, didn't have any macroglossy. So we ordered serum protein electrophoresis, urine as well, protein electrophoresis, immunofixation, and kappa lambda chains. And we are also, actually we wanted like to do a fat pad biopsy of the abdominal fat, but the nephrologist, for some reason, like, I don't know, they just like put a hold on that, and we are possibly going to, we are just like waiting for the serum protein electrophoresis, the antiphospholipase H2 report, because it takes a while, and like the urine protein electrophoresis, immunofixation, and if all that comes normal, we'll do a kidney biopsy. But she's still my patient, and I'm still seeing her, and we don't have a definite diagnosis, but I'll let you guys know what is the definite diagnosis once we do a kidney biopsy. But what I wanted to tell you guys, and why I wanted like to bring this case, is because this was a case that actually taught me that in medicine you cannot rule out anything, because I actually saw this patient, and this is the typical case that you think, okay, the patient has heart failure, she stopped taking Lasix, she has lower extremity edema, that's because of heart failure. So like, you just like, you know, Lasix and she's responding well. So yeah, heart failure. And even in the urinalysis, like the protein was 70, so it was not more than 300. So you say, okay, it's heart failure, nothing else. But then like, actually I was rounding with the attending that the attending was a nephrologist, because here they have to do, the nephrologists have to do 2 weeks of hospitalist. So he actually said like, okay, we have to do a protein creatinine ratio. And yeah, like it ended up being like something completely different than I honestly didn't expect. So yeah, it taught me a lot, this case, like never rule out anything, like always without like, you know, holding on and what, like making sure this is not something else such as a nephrotic syndrome.
Wow, this is a remarkable, like a real world case where we see, maybe not to this extreme, but we deal with, as hospitalists, many patients coming in with AKI or AKI on CKD, and sometimes the diagnosis is not known. And this patient's had a very broad workup, and there's an incredible amount of data that you've presented, and still we don't know the diagnosis, but I think we're pretty much near where we should be. So there are a couple of hypotheses that are still in contention, but I was very interested to see this when you increase the amount of diuretics. Sometimes nephrologists will do this Lasix stress test to see if the patient has intact kidney function or the patient's kidney function is further progressing towards maybe requiring hemodialysis. So by giving or challenging the kidney with diuretics, if there's an increase in output, as clearly this patient was oliguric initially, so by giving the combined diuretic test, the patient did put out quite a bit of volume, so kidney function is still intact, doesn't need dialysis at this point. But I think the workup is still ongoing, and definitely if you can come back, email or let us know what the diagnosis is. So what you mentioned is the next step is just waiting for all that data to come back and then doing a biopsy?
Yeah, exactly. So the patient is a bit rebellious, and we wanted her to do like the test for antiphospholipase A, but she at first refused. And so, yeah, it was not easy dealing with this patient, but yeah, finally, like, honestly, I get very well with her. So I don't know if that made an impact. And yeah, she finally accepted like to do all her tests. And yeah, we're waiting for those results, but those like take a while. So I honestly, I don't know how much time it will take, and probably the kidney biopsy will take another while. So I will let you guys know when we have the result of the biopsy.
So interestingly, the anti-PLA2R membranous nephropathy has the highest amount of burden of thrombosis. So what you're seeing in the ultrasound there, which we were hypothesizing could be thrombosis, if that does come back as a diagnosis, that may explain why, if there is thrombosis there. So I'm still not clear, but that was one of the theories we had in contention earlier. But that would be very interesting if it comes back as membranous. What do you think, Menju?
Yeah, I was thinking if it's in the aorta, I think that might be a little rare for a membranous nephropathy to cause like kind of aortic thrombosis. I mean, for that, I think sending antiphospholipid makes sense. I would think membranous more like a venous thrombosis, which is not uncommon, and that could cause this kind of picture as well. But yeah,
I wanted to add something. Pardon, maybe I didn't emphasize this enough, but in the Doppler it said that there was like the last sentence says possible tortuous area of vessel or stenosis with suboptimal imaging. So yeah, I don't know if that vessel word refers to a vein. So yeah.
Oh, okay, yeah, because membranous does have a high propensity for renal vein thrombosis. So that's right in the area. It's the vein, not the aorta. but that would be interesting. If you have renal cancer, that could explain that. But yeah, it's kind of weird. I need more information. So very unusual case. I really appreciate that. That's definitely a mind twister, and I definitely will be exploring some of the stuff we discussed. It's always good to go back and read about these things. Any reflections, Menu, about this case? We still don't have an answer, but
Yeah, this is such an amazing case. Ricardo is determined to leave us some suspense. But thanks for this great case, Ricardo, and thanks for your great reflection. I kind of agree with you. We had a patient who also had like similar presentation, but then her gradient actually improved with some hemodynamic management. So I think that sometimes could help us differentiate whether it's due to a hemodynamic issue like a heart failure or like underlying glomerulonephritis. But I think once you see that high amount of protein, then you kind of have to think about consider that as a glomerulonephritis until proven otherwise.
Yeah, thank you very much. Thank you very much, everyone, like for having me here and giving me like the opportunity to present this case.
oh, thank you, Ricardo. Another fantastic case and so well presented, so expertly presented. And we'll go to Aisha for teaching points. If you're able to capture all those fabulous points Menju had mentioned.
Hi, thank you so much, Ricardo, for that case. That was such an interesting discussion. Let me know if my internet cuts off, please. So we have a patient with lower extremity edema, a female patient that I presented. For this case, we bounced around a lot with liver, renal, heart. Which one could it be? We had reasons to suspect any of those could be the reason. So when you're talking about lower extremity edema, you need to focus on the etiology. So you need to think about where it could possibly be coming from. Could it be from the liver? Could it be from the kidneys or the heart? Or it could be something to do with the pressure. So it could be due to decreased oncotic pressure in tissues. It could be due to low protein states from the liver, or it could be lymphatic tissue leakage as well. But when you're looking at the edema, you have to focus, you not only have to focus about where the patient presents. So in this patient, it was the leg. You have to go up north and see if the patient has edema in the face, is any other part involved as well. Another important point to discuss is, was the edema unilateral or bilateral? Because it might indicate issues with the hydrostatic pressure, or it could be due to a localized obstruction in the venous system or in the lymphatic system. As Mingyu said earlier on, it could be due to infections, so such as Hep C or B, which is associated with MPGN. Medications also play a role, but in this patient, it was amlodipine that could ever so slightly contribute to the edema. The others were pretty standard. And then we started, and then the patient presented with tenderness on physical exam. So when we have tenderness on compression, we need to figure out if that's something we need to emphasize on, or is it not really an important factor? Because the edema, if it's intense enough, so it was 3+ here, is that contributing to the tenderness, or is the tenderness just going to subside by itself? And the tenderness, it could also be because of inflammation. The inflammation could be in the muscle, it could be in the bone. And then we moved on to the labs, where we found a non-anion gap, which we could be suspicious of RTA or a renal etiology. That's when we started focusing a lot more on the kidney. Moving on from the leg, we focused on the kidney. So we found out that there was also low albumin. Could the low albumin be due to being lost in the gut, or is it because straight from the liver? Are the liver enzymes abnormal? And then in the labs, we also saw that there was high creatinine, which we can go back to saying that it could be MPGN due to hepatitis, but we need to get more numbers on the urine. We need to figure out if it's a nephrotic syndrome, nephritic syndrome, and to further support our potential differential diagnosis, we can do a renal biopsy to rule out nephritic and nephrotic conditions, especially because this patient sorry. So she also had ANA, but in this case, ANA, because she's a female patient, female demographics could have a false positive. So we need to keep that in mind. And some few more causes could be that it could be a vascular complication. The creatinine elevation could be due to a vascular complication, and the low velocity that we saw in the renal duplex, it could be due to a stenosis in the vessel. Yeah, those are the teaching points I have. Thank you.
Thank you very much, Aisha. That was a very good summary of all the teaching points. So many different details discussed here, and I absolutely appreciate you logging on from. Are you in Beijing currently? What time is it there?
Yeah, now the sun has come up. It was 5 a.m.
Oh my gosh!
Try
to crack this case of 5 a.m. That's very adamant. I mean, very interesting. It's quite a challenge. But I really appreciate you logging on from vacation. And again, Ricardo, thank you for such an intriguing case. And do come back to us with some clarification on the diagnosis. So thank you, everybody, for logging on. Take care. Have a good rest of Tuesday. Bye.
Bye. Thank you.
Bye. Thank you.